Tendonitis sounds like such a simple type of problem, can be a clinical nightmare. Tendonitis has a typical pattern of becoming chronic and persistent and resistant to all types of treatment. So it's quite important from a clinical perspective to try to identify early signs of a tendonitis and institute the most appropriate management measures. It sounds like such a simple diagnosis. Tendonitis meaning an inflammation of the tendon, and the common areas in the body that you would see would be an Achilles tendonitis at the back of the heel, a patella tendonitis around the kneecap. In the lower limb, they would be the commonest ones, and in the upper limb, by far the two commonest would be in the elbow, which would be a tennis elbow or a golfer's elbow, which are the two tendons that attach on either side of the elbow, and in the shoulder, the rotator cuff tendons, which are tendons which keep the ball and socket well aligned. So they are the four common regions where we see tendon issues. And the reality is that there's a big scale of severity from a little bit of irritation of the tendon and some inflammation around the surface of the tendon to much more persistent and lasting inflammation that actually penetrates deep into the substance of the tendon, and that makes it a much more difficult kind of an issue. Some medical folks will classify the difference between a tendonitis and a tendinosis. It's a little bit of an academic distinction, but the tendinosis really refers more to what happens when the tendon has been inflamed persistently for long periods of time, and then what you actually start to see is degenerative change in the tendons. So most people aren't really aware of this idea that just like degenerate joint change, what we call wear and tear or arthritis or whatever one term wants to use, tendons can also be subjected to degenerative change, and that means that their ability to handle loads and generate force and strength from the muscles can be compromised. So that is an important phenomenon to recognize. From a treatment point of view, the biggest priority really is early recognition. Very often people start off and describe a history where it was quite a simple bit of activity, maybe a bit of pruning in the garden, chopping logs or overhead reaching, painting, things like that if it's an upper limb problem, or increased walking or climbing steps if it's a lower limb issue. And it just starts off as a bit of a niggle, and the assumption is that it's a bit of muscle soreness from increased activity, but it remains at a low persistent level over a number of weeks, which first of all tells you that it's not spontaneously resolving. And then usually either it just gradually deteriorates and becomes more severe and more limiting, or something else happens that exacerbates it and pushes it over the edge. So the first take-home message is that early signs of tendonitis, if it's a low-grade inflammation that's not going to cause any issue, it really should resolve within a week to 10 days of the aggravation. But if you're finding the symptoms that are persisting for longer than that, then that can then start to become a more chronic, persistent issue, which then often requires much more complex kind of management. The differential diagnosis again with a tendonitis is whether there's a partial tear of the tendon. So a tendon is basically just like a rope, or most tendons are. There can be slightly different shapes, but if inflammation is one issue, but if you tear some of the fibers of the tendon, then you're looking at more structural damage, and it still presents as a sore tendon when we examine it in terms of how people are limited in their function, but it's actually a bit more going on. And at the very severe end, and I'm sure you've heard of people who've had tendon ruptures. Achilles tendon rupture is the common one, usually middle-aged guys. The classic history is kicking football with the kids, or stepping off a curb, or running to get out of the way of a bus, and the tendon just snaps. That's much less common in the upper limb, although you will get spontaneous ruptures of the tendons in the shoulder. Again, that tends to be an older age group, usually over 50. So there's often a history of vulnerability of the tendon. From a treatment point of view, really, if the tendon is inflamed, the first priority is to try and reduce the sensitivity of the tendons. And there are various kinds of anti-inflammatory measures. If there are mechanical problems in the area around the tendon, then it's really important to try to address those because if the tendon is getting repeatedly irritated just with normal daily use, then it really never gets a chance to settle down. And one of the difficult things about tendon issues is that the tendon does not have a good blood supply in general. So when it gets inflamed, it can be slow for all of the inflammatory materials to be removed from the area, and also limited circulation means that it's a slow tissue to repair, much different to say the skin or to bone. So that is one of the downsides of tendon issues. So part of the treatment is to try to stimulate repair, but not stimulate too much that you cause an aggravation or a provocation of symptoms. So it's getting that balance. As I say, the other key issue is to identify why the tendon is overloaded. Is it a flexibility deficit from the tissues in the area, or the particular muscle and tendon that's inflamed? Is it an overuse injury because of unfamiliar activity? Is there a muscle imbalance or a weakness issue? So all of those things have to be identified, and there's a very different kind of treatment regimes depending on what those deficits are. On the more severe end, if the inflammation is slow to settle, then some people will opt for a cortisone injection, which is a strong anti-inflammatory injection that used to be used very routinely in the lower limbs, but there is a small risk of tendon rupture. So it's much less common now to see the Achilles tendon or the patella tendon being injected with a steroid to try and get it to settle down. And certainly over the 30 years I've been in practice, we see the lower limb cortisone injections being done much less frequently. It's still a pretty common procedure in the upper limb. And if we see particularly a shoulder or an elbow tendonitis that's very angry and not really seeing response to 3 or 4 sessions of structured physiotherapy, then a cortisone injection could be something that could be considered. There is a mixed opinion in that some of the evidence would suggest that although the cortisone can give you an immediate temporary relief, it can often facilitate a more persistent issue further down the track. But sometimes it's a case of just having to take that chance to get an ease of symptoms. So take home message there really is, if you're getting symptoms in the tendons, okay, and it's not resolving quickly within a week to 10 days of aggravation, then really you need to get it addressed so that proper measures can be put in place to try and facilitate recovery. Otherwise, it can become one of those chronic tendon issues, which just always has to be monitored, and one is limited in the intensity of activity that you can do, or the distances that you can walk, or the amount of gardening or overhead reaching. So there are always possibilities if the tendonitis is allowed to persist unchecked. So just thought I'd give you a little bit of background information on tendonitis. It can be the clinician's nightmare, as I said earlier, because you never really know when you see an acute tendonitis, is that going to be a quick, short course of care, or is it going to be morph into a more persistent, continuous type of symptom, because it doesn't look any more dramatic when you examine it, and there is not much else to see on examination on the initial outset. So just a little word of warning. So pay attention to your symptoms. Hope you found that informative. I'll see you again on another video. Bye for now.